So my sort of focus really is just to talk in some respects about some of the changing things associated with breast cancer and some of the aspects of its management and the process that they go through, and then just some of the what I consider to be some of the big breakthroughs more recently in terms of some of the change management, which I think I personally thought was actually quite important and useful information. So, so I'll start. So, just in terms of, again, this is a slide that lots of people have seen. I think that the salient point is that it's a common disease. And when they talk about those statistics of 1 in 8, for example, they're not just talking about invasive cancers, it's also DCIS as well, or LCIS. It's the whole group. So not everyone is going to have invasive cancer, but they obviously have a whole breadth of presentations. And you know, generally speaking, the survival, you know, when they give about their statistics, the disease itself is very varied, which I'm going to touch upon. They present with different presentations. Some are very early, very good prognosis. So we know that for very early stage breast cancers, where you know maybe it's a grade 1 and it's a small tumour, no nodes, hormone positive, their survival will be in excess of 90%. And you get someone who presents with 18 nodes, they've probably got about an 80% chance of it reoccurring. So, you know, these figures, when they quote them, they're actually, in some respects, not very useful, because you're trying to homogenise something, when in actual fact the disease is actually extremely diverse. And I think that's one of the key things that I hope you get away from this, that it is not one disease. It is a set of diseases, and as such, the treatment has to be personalised according to their risk factors. And again, you'll probably see if you have patients that are treated in different groups, different organisations in Melbourne, whereas you'll find that there is quite a lot of variability in treatment, and that's because the disease is variable. And even for that one presentation, you will have some variations around a theme. The other issue is that it also depends on the type of disease in terms of recurrence. People often ask, you know, doctors, you know, when am I clear of disease? And what I'd have to say is that for someone who's got triple negative disease, you can be pretty confident if it doesn't reoccur in the first 5 years, and they're probably going to be okay. If you've got hormone positive disease, they can relapse even 20 years down the track. And unfortunately for that group of women and men, you don't have a point where you say you're actually okay. They often are never really okay for a very long time, and that's something conceptually they often have difficulty with, because they talk about this concept of remission and when will I be okay. For some malignancies like bowel cancer, we're pretty confident if they get to 5 years they're going to be okay. But in breast cancer, triple negatives, 5 years is not a bad endpoint, but for some of those hormone positive breast cancer, they can recur you know, many years down the track. But it is more, if you're going to run into problems, it's more common you have that sort of curve that starts off, and then when you get to 5 years, it sort of drops off. So one of the issues is this concept of what are the risk factors, you know, why do people get breast cancer? And certainly, you know, age is one of the things that occurs. And again, I'll talk about this concept of screening, which sort of fits into that. And it's just to give you an idea that clearly as you get older, the risk actually, you know, changes significantly. So you can sort of see for this age group, it's relatively the most infrequent. And then as you get older, clearly it becomes more common. Family history is something, and this is something I sort of discovered. If you actually go to the cancer website, again, sometimes people might present you and say, look, you know, I've got this family history, what is my risk? What should I do about it? You know, mum's had cancer. There is this website, if you go to Cancer Australia, it's the FRABOC website, and it's a really nice program that I discovered preparing for this talk, where you actually just plug in the numbers. So it'll say, if you've got a first degree relative, your mother or father, you know, when they had, it'll ask you the questions, was there bilateral disease, was there ovarian cancer, was there Jewish ancestry, and it chucks out a little thing that sort of says, your risk is no greater. So I chucked in some of these numbers, and it just gives you an idea of how it changed according to some of the risk factors. So for this here, where you've got your mother with breast cancer and she's more than 60 years of age, then the risk is not that much greater than the general populace. If you make that person less than 40, which is obviously more significant, it increases the risk by 1.5 to 3 times that of the general populace. If you add in the mother and a sister, it's very high, and there's a significant risk that the person's got some sort of genetic underlying predisposition. So again, the point of that is that family history is important, but it's also how many first-degree relatives, whether they are, whether you've got a number of generations in line, whether there's bilateral disease, whether they've got ovarian cancer as well, whether there's Jewish ancestry. So it's just something to consider. And I just felt that that website is something that you could actually look at, put in your favourites, because I'm sure that you get asked that question. They'll come back to the neural practitioner and say, well, my mum's just been diagnosed, what does it mean for me? And it actually gives you recommendations on what you should do. You know, whether or not they should just have screening mammography or whether they should be referred off to the genetic counsellor or whatever. And I actually found that quite a useful, very easy to use website, and it takes about 60 seconds. In terms of knowing that as well, there are obviously these mutations that are known, and you've probably heard in the media recently that there are evolving genetic mutations that they're finding, but these are the classical ones that they look for in their screening as well as some others. And again, just to give you an idea, that if you have a known BRCA1 mutation, the chance of breast cancer is about 65%. So these women, if they've got a known mutation, will often have discussions about prophylactic mastectomy. For ovarian cancers, it's also relatively high, and with the BRCA2s, it's a little bit less than that. But again, there's that genetic predisposition. Again, when they've got those genetic mutations, they often go through some form of familial program where they actually, as part of the process, they're actually informed even before they have genetic testing. They often spend about an hour and a half with a genetic counsellor before they even go in that pathway, and it's pretty well supported because it obviously has significant ramifications for the individual and their families. Hormonal therapies, this is probably something else I'm sure you've got asked about, particularly when they had some of those publications, those very large cohorts of populations looking at this issue about hormone replacement and about what was the risk associated with it. They were extremely large. The Women's Health Initiative was an extremely large cohort, and they were looking at a number of factors associated with hormone replacement therapy. And certainly since that publication, I mean, I've certainly noticed, and I'm sure you have too, that people have just often just stopped using it. And again, if you look at the practice in that particular study, they were often on hormone therapy for a median of 8.5 years. They were often on it, into their late 60s and even early 70s. And there was an increased risk of 2.5%, but in absolute terms, it was pretty small. It was 8 cases per 10,000. And again, I'm not suggesting that everyone should go on it, but I think it's certainly got a lot of media coverage, and it really, I think in some respects, pulled things a little bit out of proportion in some regards, because for some people, they can have terrible symptoms from being postmenopausal, and of course you need to do the risks assessments before you initiate it. But I thought it was interesting when you look at the absolute numbers, it's not quite how people might envisage it. There was also the Million Women study. They sort of found that the risk of recurrence was doubled, but it was also found to be higher in the combination, whereas the estrogen only was less, although you wouldn't do that to someone who's got a uterus inside you. But so I suppose my point with this slide is really just sort of saying how I don't think it's an absolute contraindication if you haven't had a history of breast cancer, or if you don't have a strong family history, then if they need to have it as far as their management, then it's not unreasonable to discuss it. But again, realistically, I think people wouldn't be on it for extended periods of time, and it needs to be evaluated. But I'm just think that the purpose of this was just to put it into some sort of perspective that it's not quite as rampant as people had imagined to be. But interestingly, there has been some suggestions that with the drop of usage of it, that in some sort of cohort studies there has been a slight reduction in breast cancer in those cohorts. And again, it's only really relevant for hormone-positive breast cancers. Some of these other risk factors, again, it's basically hormone exposure. So if they've had children at a later bearing age. No children at all. Radiation exposure is certainly something that is considered when people have got radiotherapy for whatever reason. The classical women or people are considered in this situation are those that with Hodgkin's disease, where they have mediastinal radiation, for example. Their risk of breast cancer is higher, and it's greatest when it's in young age groups. So, for example, some of the people who have curative treatments, they'll be followed up in long-term sort of outpatients look for complications. but it is something that is certainly a concern and would be seriously considered in young patients of that age group. If people have prolific atypia, early puberty, late menopause, again, that concept of being exposed to high levels of estrogen over a long period of time. Lifestyle risks, this is something else that again is, people often ask about. Certainly being overweight, a high BMI of greater than 25 kilograms, not milligrams per metre squared, is associated with an increased risk of 20 to 40%. And again, there are a number of theories as to why that might be, including increased levels of estrogen, insulin, and insulin-like growth factor, for example. But certainly there's been a lot of evidence to suggest that people really who are overweight have a higher risk. And in fact, those women that have had breast cancer, who then continue to be overweight, have a poorer outcome compared to those that get back to a normal BMI. So I think that's certainly an issue. Drinking is something that, again, it's interesting, we talk about that with our patients. They don't seem to sort of appreciate the association between alcohol and high risks, and in fact it's about 7% per standard drink per day, like if you do that on a regular basis. So again, that's something that, again, all of us can potentially work on preventions in that respect. Fat intake, it certainly hasn't been shown to be clearly an independent factor if the person has an otherwise normal BMI. Red meat's not clearly the case, although again we tend to not encourage people to have more than two servings a week because of the associated with bowel cancer. Vitamin D replacement, not clearly the case either. Lack of exercise, again, it's a bit soft, but again, maybe in association with the BMI, but again, this idea that it may actually have an impact on fat distribution, for example, but it's not as strong. Probably the strongest of those is the BMI and the alcohol. But again, it's something that we can work on, and generally speaking, most of these things are good for almost everything anyway. Again, I find that when I take people's histories, a lot of people from 50s on are drinking regularly, and it seems to be more common where they often will drink 2 or 3 glasses of wine a day. I don't know how you find it, but I find that seems to be becoming more common, and it's a bit of a concern actually. So the concept of screening mammograms, again, I thought there was something just to discuss. The question is, when should you do it? In terms of the recommendations, it's between 50 and 74 is what the guidelines actually recommend. But you always have those people that present, in their 80s, and it's like, well, should they be having mammograms or should they not? Is it appropriate? Is it not? And it's really about what their other comorbidities are and what their life expectancy is likely to be. So if you've got someone that's outside that range that's otherwise extremely well, and you discuss with them, I don't think it's unreasonable, because if you look at the incidence goes up when they get older. So I think if they're otherwise someone that you would aggressively treat and they're otherwise pretty good, there's an argument to continue with those individuals. But there's no clear recommendations. What I found was that they said if their likelihood of being around in 10 years is pretty likely, then you could consider it. There's also a controversy about what sort of impact has it actually done, because there was in fact a publication which I referred to in the Lancet about whether or not we should or shouldn't actually do it. Certainly there's been a number of studies where they've looked at meta-analyses, and the take-home message is it probably reduces mortality by about 20%. But interesting, that's a very long slide and you'll probably be able to get those, but the point that it basically made is that they do discover breast cancers, but they also discover breast cancers that may in fact not be normal. And that includes DCIS and small tumours in women that are otherwise quite old. And what they found with this study from the Lancet was that for every tumour that is going to make a difference, you may find 3 others that don't. But I think at the moment that's the best that we have. And I would imagine that would be, it's a bit like the prostate thing. I would imagine that people who have a diagnosis, who they said, well, it's not going to kill you, I would suggest that those people would still feel comfortable at not doing something about it. So, there's a limitation in the study, in the screening program we have, but 20% isn't bad. So I think at the moment, certainly there's been no suggestions that screening will stop, but it's just something to recognise. MRIs, again, it's a question that people often ask, what's the role of an MRI? When should you do it? When are the indications? And I suppose, again, it's not something that we routinely do. MRIs also are fraught with issues. They find a lot of lesions which are never going to become a problem or are not in fact malignant, and the studies when they've used them outside of these specific situations have found lots of false positives and lots of anxiety. So it's certainly not something that would become mainstream, but it may have a role, certainly for women who have got documented BRCA mutations, for those that don't want to have a mastectomy. It may be considered for people who either are a first-degree relative where there's a high risk and they don't want to have their testing done and they're young. Again, it's something that would have to be discussed, but that may be a situation where they might be used. Or if they've got someone that's got a pretty high risk and they're younger. I mean, really, its role is in people who've got very dense breasts who you have some limitations with mammography and ultrasound. But generally speaking, it's usually used in people with BRCA mutations. So in terms of its presentation, I mean, again, I'm not going to tell you anything that's new. I think the only thing I really wanted to sort of focus on was inflammatory breast cancer, and that's probably one of the things that hopefully, again, it can be a bit of a trap. I mean, it's uncommon to get mastitis in someone that's not lactating. Again, my perspective is obviously very skewed because I'm sure that you see lots of things that I would never get to see. So I don't work in general practice, but one of the things is that you do occasionally have those people that have been treated, for weeks on end for mastitis, and someone who's 50 who ends up having inflammatory breast cancer. So one of the things that I think is important is that, for someone that's not in that situation, a high level of suspicion for malignancy in someone who presents with mastitis is something that I just wanted to highlight. I thought that was actually relatively important. Again, just in terms of what we actually do, this is more in terms of background, but clearly, once a diagnosis has been made, the purpose of what we do at that point really is to work out how extensive the disease is, and is it localised, is it curative, or is it metastatic disease? And again, once we've actually made the diagnosis in terms of pathology, they will obviously have their breast imaging, they may have a biopsy if there's a positive clinical lymph node, and then a determination as to whether or not they should have a mastectomy or lumpectomy or axillary clearance. And then, of course, then they would, depending on the presentation, they would be discussed at an MDT meeting, and you would usually see a medical oncologist and possibly a radiation oncologist if radiotherapy was considered. I wanted to focus a little bit on this, which again comes back to that variation in treatment. So in terms of decision making in the adjuvant setting, so this is curative we're talking about, there are the classical things that we would look at in terms of risk factors. So really what we're trying to do is, person presents, we're trying to look at all the aspects of it. How likely is this disease to come back? And if it is, what interventions do we have to reduce that risk of coming back? So there's the classical things, the size clearly. If it's a very large tumour, it's been there for a while, has a greater chance of metastasising. The grade, so we have 3 grades, 1, 2 and 3, and they're basically, there's a very standardised way of assessing it. It is still subjective in the sense that the pathologist will go through the number of criteria and divide them into all those 3. Grade 3 is obviously very aggressive, grade 1 is a more indolent tumour, generally speaking. Their hormonal status, so whether or not the tumour expresses estrogen and progesterone, and again, the stronger it stains, the more hormone positive it is, and I'll explain in a minute that there are some prognostic implications for that. So they often will give you a concept of how many cells are stained, whether it's 1, 2 or 3, and that will have some prognostic implications. The more strongly positive it is, the more responsive it is to hormone therapies, and therefore, it certainly affects the biology of the cancer. The nodal status, clearly no nodes is best, and then the greater number of lymph nodes that you've got, the higher risk of recurrence both locally and distantly. Lymphovascular invasion and neurovascular invasion are just pathological features that have been shown to be independently, if they're present, increase the risk of recurrence. So this is where I wanted to actually focus on, because this is new, well, newish, I suppose. So what's classically happened is people will look at those features, and there really isn't a clear algorithm. People would look at all those features about the size, the grade, and then get a feel for the general risk, and particularly if some of these things might move together. Not infrequently you will have someone who's a large tumour, high grade, multiple lymph nodes. It's a bit of a no-brainer that person's got high-risk disease. You sometimes have distorted things where someone might present with a small tumour, not that high grade, but 3 lymph nodes. Well, if you think, well, that's a bit of a concern, it's a small tumour, but it's really metastasised. But, there isn't like an algorithm, but people would generally get an impression of what is likely to happen with that. They've actually looked at some of the genetics of these tumours as well. And what they found is that they looked at a whole ream of genes in all these breast cancers, and they tried to sort of clump them into the ones that did really well and the ones that did badly. And what they found is they could subtype them into these different groups: luminal A, luminal B, HER2 overexpressed, and triple negative. Okay, and then what they've tried to do is they've tried to also then go backwards and say, okay, right, of those groups that seem to be genetically in the same group, do they have some characteristics on their pathology that you could use as a surrogate? And again, what they sort of found was that if you looked at them, generally speaking, that the luminal A's, which tend to be the least proliferative, the ones that were, you know, possibly had the better outcome, generally speaking, were strongly ER and PR positive. Ki-67 is a sign of proliferation, and so they tend to have, that actually should be less than 15%, sorry. But it was basically not proliferating so great, and they were HER2 negative. You had the luminal Bs, which was higher risk, so still potentially estrogen positive, but the progesterone was less expressed. Again, they might have a high Ki-67, or they could be HER2 positive. The HER2 overexpressed were HER2 positive but had no hormone positivity, and then the triple negatives are the ones with everything there. So when you see a patient that's got triple negative, that's usually very concerning, and they can often, if there's a family history, you'll find that some of the BRCA1 mutations in particular present with the triple negatives, okay? So the point of this is that, for example, what they were saying is that, you know, if you have that luminal A, even if it was a slightly bigger tumour, all nodes positive, that wouldn't be the same as someone with, say, a luminal B, that the biology of it was the driver. And in fact, you can actually do some genetic testing through a thing called OncoDX, there's MammoPrint, and certainly OncoDX is available through a process that you can send off, and they'll give you like a risk score of how beneficial chemotherapy is likely to be. They give you a low risk or a high risk. And they'll give you an indication of whether or not to consider sort of, a chemotherapy in that group. The difficulties at the moment is that it's expensive and it's done in the States, so it varies according to what the Australian dollar is doing. So at the moment it's about $5,000, it takes about 2 weeks. You could end up having an intermediate result, which is being studied at the moment as to what to do with people. So you could pay the money, 2 weeks later down the track, intermediate score, still don't know what to do. So I have to say I do discuss it with people. I've had uptake of one patient so far. They often just say, no, I'm not spending $5,000 on that. You know, I don't want to do that. And again, it is logistically quite challenging at the moment. But I suppose my point that I'm making is we're starting to look at these profiles. The problem is that, well, at least with this, there's some suggestion that they might be predictive for responsiveness to treatment as well. So there's the prognostic, how bad they're going to do, and then the predictive of how good something will work. And at the moment, the St. Gallen Guidelines talks about using this profile as one of the tools to choose it. But again, it doesn't, no process is perfect. You know, like you'll still find people that you think, gee, I know that's what it says, but my gut tells me that that's not great. And I can think of an example just recently where we had someone who presented with a 7mm grade 2 tumour, and the metastasis in the node was bigger than the primary. Now, it was hormone positive. The Ki-67 was about, it was 20%, and I had a chat with the patient about it, and I said, look, this is meant to do well, but it does worry me that you've got a node that's positive at such an early stage. So I emailed, one of my colleagues that works at the breast unit at PMAC, and she said, well, I've just been in Europe, and in Europe it's node positive, she would have chemotherapy. And then I did one of my colleagues who worked at the women's, and she said, no, just hormones. So I thought, well, I've got 2 discordant responses, so clearly nobody knows what to do in this situation. And the patient made a decision in the end, and they were informed. But I'm just saying that, you know, it is quite a complex process, it's not simple. Again, I'm not going to go into great detail about this, except to say that clearly there are different ways of approaching the surgery itself, which is the cornerstone of early stage breast cancer. We'll aim for lumpectomy if we can. Having said that, it's just something I anecdotally have noticed. There seems to be an increase in the number of young women who are electing to have mastectomies. I don't know if you've noticed that at all, but it just seems to be where the discussions are had, that there seems to be a slight increase in radical approaches, but in principle, if it can be resected and you can get a good cosmetic result, that's what would normally happen, having discussed it with the individual. And of course, if they have a lumpectomy, generally speaking, unless they're incredibly old and the tumour's small, radiotherapy would be considered standard of care because of the risk of recurrence. And mastectomies would be considered if you've got a recurrence and you've already had radiotherapy. If it's a very large tumour and you're going to get a bad cosmetic result, if you've got inflammatory breast cancer, you would not be thinking about breast-conserving surgery. And again, if someone's got a known mutation, then you're often talking about prophylactic mastectomies anyway. So at least, unless they don't want to do that, that would be the indication. Sentinel nodes, it's for people that have got clinically negative lymph nodes. If they've got radiological or clinical evidence of lymph nodes, they should have an exiliary clearance. That's often confirmed with the biopsy beforehand to make sure that's what you're dealing with. But sentinel nodes are done clearly to decrease morbidity, because the role of the lymph node being removed, it's for staging. It doesn't have any impact on survival itself. So the purpose of doing the sampling is to actually give you an idea of how high risk it is of coming back. Again, not to go into great detail, clearly there are adjuvant therapies involved. There's chemotherapy, there's radiotherapy, there's hormonal therapy. And again, it's individualised. There are a number of treatments. What I can tell you is that you do your risk stratification, and for people who have high risk disease, they often are offered more intensive treatments, and there seems to be the greatest benefits are for people with high risk disease and also often premenopausal women in comparison to postmenopausal women. That's partly due to their disease. But it's risk stratified, and so if they've got low risk disease, generally speaking, you would consider a less intensive treatment or not at all in some cases, and I'll go through that in a minute.
I have a question. In a patient that's got lymph node involvement, and after having a biopsy, it was reported as being inflammatory response. What does that mean?
So again, so you've had someone who's had a lymph node involved, and they said it was disinflammatory.
Yeah.
What you're saying?
Yeah.
When they resected it.
Yes. But there's still sign of metastasis, but
yeah.
it's just inflammatory.
So I presume what it means is that when they actually analyse the nodes, because particularly now that they're doing sentinel nodes, they've got few nodes to process. They do a lot more cuts, and they also, even if it looks negative on H and E, they then do additional stains because sometimes they can identify what they think are malignant cells by these additional stains. They're not seen otherwise. And again, even with that, people are not sure about what that means. So you have a lymph node. If it's greater than 2 millimeters, it's a macroscopic tumour. If it's less than 2 millimeters, but still a cluster of cells, it's a micromet, which probably increases the risk a little bit, but not the same as an actual node involvement. And then you have individual cells where you can just see an occasional, cancer cell, and that hasn't clearly been associated with increased risk. So if it's just inflammatory, they're just saying that there's nothing malignant in there, but there might be some inflammatory cells. So you could get an inflammatory response to a primary or any other reason. It just means it's negative.
Or the punch biopsy.
Yeah, that's right. So a reaction to something, yeah. So with regards to tamoxifen, again, I'm not going to tell you much about that, except to say that for strongly hormone-positive breast cancers, they actually can reduce the risk by almost 50%. So if you've got someone who actually presents with a strongly ER/PR-positive breast cancer, it actually is quite significant. People think because it's not chemo, because it's toxic or potentially toxic, it must be better. But in actual fact, that's not the case. One of the issues, really is compliance, and that can become quite problematic because of the side effects, and they can be challenging to manage. But it is an effective treatment for people who've got strongly hormone-positive breast cancer. Clearly, the greatest things that people complain about are the flushing associated with it. There are obviously a very slight increased risk of endometrial cancer and DVTs. They're small. It's I think the incidence 3 per 1,000 of endometrial cancer, and it doubles that, but it's 6. It's not massive, but clearly you need to monitor people who are on tamoxifen. If they're not menstruating and they have post-menopausal bleeding, they need to be assessed with an ultrasound and then seen by a gynae or a women's health to assess that. The other thing about the menopausal sort of symptoms is that it's sometimes challenging, and I find that it's worse when they've been premenopausal, they've had chemotherapy, they suddenly get that rapid drop in estrogen levels, and it's that rate of change that seems to make the symptoms worse. if you give tamoxifen to someone in their 70s, they are much less likely to have those sort of side effects. So I think it's partly depending on whether they're being forced into menopause through treatment. There are things you can do about it. You can try all the natural therapies. You can use things like Effexor at a low dose, and that's been shown in randomised studies to be effective. You can use gabapentin as well, a dose of between 1 and 300 milligrams a day, and that seems to sort of reduce those vasogenic sort of symptoms. So we sometimes use that. We just need to be careful with the antidepressants. Effexor is one of the ones that's less likely to affect the metabolism of tamoxifen, but there are those things that you can do. It's not used with chemotherapy. It's sometimes used with radiotherapy, but usually it's used after they've finished their radiotherapy and chemotherapy if they have it. The aromatase inhibitors, class effect, I don't think there's any one that's better than the other. I think they're all pretty much of a muchness. And again, they were really only used in people that were postmenopausal because it interferes with aromatase and production of the androgen sort of precursors and then converting it to estrogen. They're more likely to get arthralgias with this. It's about, they quote 20%, but then post-analysis, once the drugs are out there, it's probably up to 40%. And it's classically small joint, it's classically stiffness, gets better with activity, and sometimes it can improve with time, but it can be a real issue with them. They tend not to have the issues of, there's no increased risk of endometrial cancer or DVTs, but the other thing about these drugs is that, unlike the tamoxifen in the postmenopausal group, it can accelerate bone loss. So that's something that we worry about, and we have to know what their DEXA scans are like and those sorts of things before we sort of risk verify whether to use one or the other.
Excuse me, is there good reasons why you have to stop the tamoxifen and put them over to an aromatase inhibitor? I think it's after 5 years.
So, well, I'll get onto that, yeah. So one of the things about hormonal therapy is, there's this, like, as you can imagine with all other things, there have been all these studies looking at how do we use the drug. So how do we use it, what order do we use it, how long do we use it? So historically what's happened is that the aromatase inhibitors have been compared with tamoxifen. So in the past, people just got 5 years of tamoxifen if they could get to 5 years. And then these AIs came on the market and they started to compare them. So they did an aromatase inhibitor any of them, they were compared 5 years to 5 years. The difference between the two of them was actually quite small. It was probably like about 1.8 or 2% absolute difference, or about 4% difference in disease-free survival, and about 1 to 2% difference in overall survival in some of the studies. Some of the studies didn't even show a survival advantage, but there was this idea that maybe some subgroups who had worse biology, the PR negatives, the HER2 positive, that maybe the AIs might be better when they've done these sorts of analyses, right? So then the question was, well, do you need to, is it 5 years that you need, can you do less than that? So there was one of the big 98 which looked at 2 years of tamoxifen or 2 years of an AI and then swapped them over, and then they also did 5 years of an AI and 5 years of tamoxifen. And what they found was that if you basically got exposed to an AI, you gleaned some sort of additional benefit to 5 years of tamoxifen alone. Then there was this study, which is how things have suddenly changed, and there was the soft study, which was presented at San Antonio and also was in the New England Journal, and this actually looked at hormone therapy in young women. And this is one of what I think is pretty impressive data. It was presented by Prue Francis, actually from Epidemiology, so it's an Australian, it was an international study, but Prue Francis was the primary investigator who presented. She did a lot of work, invested 10 years of her life in it, so it's pretty impressive. But the bottom line was that when I looked at young women, historically, tamoxifen is pretty much all that you could do unless they became postmenopausal for whatever reason. And what they did was, they got women that had or did not have chemotherapy, but still had ovarian function, and then they randomised them to either having tamoxifen, or tamoxifen and Zoladex, or tamoxifen and Aromatase, which is another one of the AIs. And what they found was that if you looked at the group that had chemotherapy, that there was a difference in disease-free survival. So this one here is basically tamoxifen alone. This is tamoxifen with an AI. This is tamoxifen with Zoladex, or whatever ovarian suppression they use, so they could have radiotherapy or a nephrectomy. And this is the group that had the AI. So that sort of suggested that there was an impact if you made them postmenopausal in some way or form, which is why maybe some of the benefits of chemotherapy for some of those groups are that you're actually switching off the ovaries. And this is probably the first definitive study that they compared all of those presentations. And so what this actually means now is that if someone has got high risk breast cancer, that if they've had chemotherapy and therefore they're considered to have high risk to have chemotherapy in the first place, if they still had functioning ovaries, you would talk about possibly considering some ovarian suppression and maybe using an AI. So that's something that's pretty new since the end of last year. The problem is that Zoladex isn't available unless they've had no chemotherapy, and that group didn't benefit from it, and I'll explain that in a minute, or they have very advanced breast cancer, so there's a bit of a problem with that. The interesting thing was that the group that didn't have chemotherapy, didn't matter what you did. Tamoxifen was the same as tamoxifen, and Zoladex was the same as Zoladex and AI. And what they were suggesting that group had such a good outcome that it was very difficult to make any difference. And it was also reassuring in some respects that people were able to generally pick the good group to avoid having chemotherapy. So that's one of the new things. Getting back to your question about length of time and what to use, this is the Atlas study. This is the other thing that also changed. And basically it was 5 years versus 10 years of tamoxifen. Oh, sorry, getting back to the other slide, the other thing that I failed to mention was that the women who are under 35, they had a difference of 15% in their disease-free survival. So that group, the under 35s, that difference was even greater. So that was also, again, I don't know that in the article they talked about what their biologies were, but what it suggested is that for the very young women, that difference was greater. So those figures are the whole group, as a group, and they probably have people up into their 50s. But the young women had a significantly greater. So again, if you've got someone who's under 35 with breast cancer, that's usually not a good thing anyway, that you really have to seriously think about discussing with them that issue about, suppressing their ovaries. And that comes with a whole gamut of other issues. And again, often in that situation, we probably get input from an endocrinologist because we're going to have lots of potential complications down the track with regards to that. The Atlas study was 5 years versus 10 years tamoxifen, and again, the take-home message from that was that there was about a 29 to 30% reduction in breast cancer mortality from extending it to 10 years. The question is, what does that mean if you give someone an AI and you've given them 5 years from the beginning? Nobody knows. We don't know that yet. But generally speaking, I think what it means is that if you've got someone who has a high-risk cancer, who's presented with really concerning features, you probably would be reluctant to just give them 5 years if they were going okay with their treatment. And you could, you could do another thing. You could swap them over to tamoxifen if there was no contraindications, because there was a study, the MA17, that did the opposite order, where they had 5 years of tamoxifen and then went on to 5 years of an AI. So you could extrapolate on that. The problem is it's a bit of a no data zone, but a lot of people, particularly with high-risk disease, feel uncomfortable about coming off their hormone therapy. I think what you can say at least, even though it's a bit of we haven't got the answer to everything, that possibly for that high-risk disease you might consider extending it beyond the 5 years. But again, you need to take into consideration all the other complications from using that treatment. But I suppose if you had someone who came in, was on some form of hormone blockade, and they had no side effects, they had no major complications, why would you stop it in that situation? But in terms of where the AIs fit in, which do you do? Generally speaking, what I'd say now is that if you've got someone that's premenopausal and they've had high-risk disease, you probably would think about ovarian suppression and an AI. If they were postmenopausal, unless there was some reason not to use it, for example, if they had low-risk disease, really bad osteoporosis or intolerance, then you probably would think about using an AI in some shape or form. Did that answer your question?
Yes.
Yeah, that's right. So I wanted to actually just get into this issue of Herceptin as well. So Herceptin is another drug which has been around for over 10 years now. It's a monoclonal antibody against an epidural growth factor receptor on the surface. And basically, it's revolutionised treatment, both in the setting of adjuvant and metastatic. So if you remember, if you go back to that previous one, the HER2 positive breast cancers were either the luminal Bs or the HER2 overexpressed. And they are more aggressive breast cancer, generally speaking. They have about a 20% risk of CNS disease. They can often metastasize at smaller tumours. It's an aggressively more aggressive biologically. And so at the moment, if people have got HER2 positive breast cancer, except for maybe the very small tumours of maybe less than 5 millimetres, they would pretty much all be given Herceptin. It's a pretty well tolerated drug. It's given generally intravenously. Major side effects from it is that it can cause a cardiomyopathy, and so they need to have an echo done every 3 months. It usually recovers if you stop it, but it doesn't seem to increase the side effects of the chemotherapy too much in the adjuvant setting. And again, it's something that can be used in the metastatic situation either on its own, or it can be used in combination with chemotherapy, and it seems to increase the efficacy of the chemotherapy without increasing the side effects too greatly. So to give you an idea, there are a number of studies that have looked at it. It's usually used in conjunction with chemotherapy. There was a study called the Herceptin where they used it after the chemotherapy, but we often use it with it because there's a suggestion that maybe it's a bit better. But to give you an idea, it reduced the risk of death from breast cancer by about 40%. So that's nothing to be sneezed at. And I must admit, you know, it's interesting when you now that it's used routinely, I've found at least it's uncommon for people with HER2 positive breast cancer who presented in the early stage to relapse like they would have done in the past. So it's clearly made a difference in terms of outcome, and I think it's a pretty clever drug. And I don't have any shares in much. The other thing that I want to talk about was this drug called pertuzumab. That's the trade name. But I thought this is one of those, again, new things that's recently become available. So it also targets the HER2 receptor. There are 4 of them, and they actually form these dimers. And what the 2 drugs, the Herceptin and the pertuzumab, they bind at different sites. So they work on different parts, so it's like dual blockade, okay? And I think this is really impressive for metastatic breast cancer. There was a study where they basically gave people first-line treatment. It was called the Cleopatra study. They either got Herceptin and docetaxel, this is a single drug, or they got that and pertuzumab together. And the difference in median survival was 16 months. That's not bad for cancer, because often when you look at some of the studies, it's like 2 or 3 months. So, so it's pretty impressive, and in fact, it's now available. It will be coming on the PBS. It's extremely expensive, like all these drugs are, but that's I think pretty impressive in terms of impact compared to some of the other drugs that we use where it might make a difference of 2 or 3 months. So that's big stuff. And the other one I talked about just briefly was this drug called Capcycline. Again, it's become available. We're getting it through a special access scheme, and again, it's just the concept of how things are becoming more sophisticated. So basically, Tamsin was a chemotherapy that was so toxic they couldn't deliver it. It just never got anywhere. It was just too horrible. And someone very clever decided to actually join a molecule of the drug to the monoclonal antibody so that it would be taken intracellularly and released inside the cell. I think that's pretty clever. So it's actually, again, recently been available through an access scheme. It will be available in the PBS. We have used it on some patients. It's extremely well tolerated, generally speaking, surprisingly so. Again, just to give you an idea, the figures here probably aren't as impressive as the first set, but it's about a difference of about 6 months. It was compared with a combination of drugs called Xeloda, which is an oral chemotherapy, with lapatinib, which is another inhibitor of Herceptin, and that's really toxic. People got really bad diarrhea and they felt really ill on it. So not only they get a survival advantage, but also I think the quality of life was better as well. So I suppose that was a bit of a pastiche about sort of things about where we're going with things. So I suppose the conclusions are that clearly it's not one disease, it is a set of diseases, and it's becoming increasingly complex as we understand the genetics of it. That's the first thing to say. And so the treatment is becoming increasingly personalised. But having said that, like most things in life, none of it's simple. And as we know with everything that we do, there are things where things fall between categories where you're not quite sure what to do, which is why you have peer support. But we are now looking at the biology more and thinking about, well, what does the biology tell us about this condition in terms of what the risks are? That it is being increasingly individualised. And the other thing I wanted to just mention also is just with the mastitis as well, in terms of presentations, if you have someone who's not lactating who presents with mastitis, at least have a higher suspicion that it could be malignant. Because generally speaking, inflammatory breast cancer has a bad prognosis, and you want to get onto the diagnosis as quickly as you possibly can. So I don't know if that hit the mark or not, but hopefully there are a couple of salient issues in there. I suppose I'll just open the floor to questions.
So, with our guidelines, RSUGB guidelines, category 3 patient or high-risk patient, like first-degree relative less than 45, bilateral breast cancer, for their relatives with a high risk, less than the age for starting the mammogram, should we do an annual mammogram, or should we, because the guidelines is not clear there?
So hang on a second. So you're saying you've got a patient who has a very strong family history? Yeah, I think what I would probably do in that situation is, if people have got a diagnosis of if there have been family members in that family, then the ideal situation would be to have those people tested for a genetic mutation, because then they'll at least be able to look at those things. And even if they can't find a gene, if the family history is strong, they will usually make a recommendation and say, we can't find a gene, but 4 of your sisters got breast cancer, there's something here, this is what we would recommend that you do. I would suggest personally that, if you've got someone who's young with a strong family history, there needs to be some discussion with someone from, especially, and I think it would be reasonable. We've actually got a genetics nurse here who works with PMA. It would be very reasonable to flick an email off and say, can you just discuss this with your colleagues? I need some sort of recommendations about this, because again, things need to be personalised, and if they don't fit within those guidelines, but you're worried as a clinician, they need to be discussed, because people do things outside of guidelines clearly, because that's all they are. And I think that rather than just doing something, because again, if they're young, then an MRI may be an appropriate investigation, but then if they don't fit the Medicare criteria, then they'll have to pay for it. So I wouldn't just organise it, I'd be speaking to someone about that from a familial cancer clinic, for example, and get some feedback about that. I think that would be a reasonable way to do, because at least then you can also say to your patient, look, I've discussed this with the specialty unit, and these are the recommendations that they've made if you're worried about it.
So in relation to that, I had a patient from a breast cancer family with quite a strong history, and she was on the tamoxifen prevention study. I've never been clear about the outcome of that.
So with regards to...
So she was premenopausal, as I was
So with regards to those high risk, basically tamoxifen prophylaxis reduces the risk by about 50%.
So it's quite significant.
Yeah. But again, it depends, there's strong and there's strong. Like again, if someone has a strong family history, you might consider that, but it will only help with the hormone positive breast cancers. Generally,
she hasn't got breast cancer.
No, that's what I'm saying. Like it's more likely to reduce risk factors with hormone positive breast cancer. But I think that in those days it certainly reduced the risk by about 50%. So but again, there's a whole issue with that, because there's also the aspects of screening in that regard as well that goes alongside with that as well.
I was interested to know what the current thoughts are on the risk of long-term pill use, oral contraceptive pills, for breast cancer.
Yeah, look, I had a look at that as well. I think that my understanding at least is that I think the risk is not great. That there's been a number of studies and cohort, and the problem with a lot of these studies, like even with the ones listed, is that there's a whole heap of mix of things that can contribute to increased risk, including their family history, their weight, their lifestyle sort of stuff. My understanding at least is there has been a recommendation that says you should only be on it this length of time. I think there was some sort of population that suggests there might be a slightly increased risk, but not enough that has been a recommendation that people should be on it. And even with people, who have a family history, I've not heard in the recommendations that we've got from the female cancer that they say you shouldn't be on the pill.
Is there any difference just on that with the mini pill?
can't answer that question, to be honest with you. I mean, I know that it's low dose progesterone, so I don't really know, to be honest with you. And again, I think that, you know, I tend to sort of look, I must be on the data that relates to people that have got it, because that's what I do.
Yeah.
But at least I haven't, I'm not familiar with the breakdown in that regard, I suppose. But again, there's been, and I've looked through the current sort of guidelines in terms of that, I haven't read anything that says that they make a definite comment about the fact that people with high risk, that they shouldn't be on those medications for X amount of time. Yeah. Any other questions?
Breast implant and mammogram, can you tell me that they usually ask what happened to the mammogram when they do the breast implant?
In terms of like whether it decreases the reliability of the investigation. Don't know. To be honest with you, I'm not a radiologist, so I'm not sure. I mean, I know that, you know, from the ones that I've seen, you know, you've got the implant, you've still got the breast tissue you can see clearly, you know, separate from that. But to be honest with you, I'm not sure. Yeah.
Just quickly.
Oh, sorry.
You go first. High-risk family patient with high risk of breast cancer in family. Is there a way for GPs to organize the gene testing themselves, or has to come through a specialist?
I think you can, but I think that it is such a vexed issue, I wouldn't do it. Because there's implications for that individual, there's the psychological supports that you need for it, there are implications for insurance. And I know that when they go to the clinic, they have about at least an hour and a half discussion. So I wouldn't encourage people to do that, because you could be opening up a whole can of worms. And, you know, unless you've got heaps of time, you know what I mean, I just wouldn't, to be honest with you.
It's not actually hard to get into the genetic clinic.
No, look, it's not, and there must have been, the services is very good. And again, you know, the thing that I mean, we do it all the time. For example, I mean, I'll often, and I know that with Morgan Murphy, who's the genetics nurse, you can just call the oncology department, and he's happy to receive calls or emails about it, and you can obviously refer to them directly yourself. So it's Dr. Susan Shanley, who's the geneticist that's associated with that, and there's Morgan Murphy, who's the genetics nurse. But to be honest with you, I personally wouldn't go there. The case came back positive, or it was equivocal, or they found another mutation that they don't know. You know, then it's just like, yeah. I don't know. I don't do it because I've got too much work to read. So.
And we can send them on to you guys.
Yeah, we can even again, like I said, I mean, I think that you know, you can contact the oncology department and just get Morgan's, you know, email address and just say, we've got this query, I'm not sure what to do about it. What do you think? And that's what we do. And they will often screen them and they say, look, you know, yeah, that's fine. We'll see them, or give them that presentation. I don't know that we need to see them, but I mean, they're very approachable. Yeah.
Yeah, just out of curiosity, breast cancer in male,
Yeah.
would you still find the same set of 3 receptors like in females, or?
So are you talking about, so male breast cancer is obviously not common.
Yeah.
It's associated more commonly with an underlying genetic predisposition, but not exclusively so.
Right.
They're usually hormone positive. They're more likely to present late because people don't think men get breast cancer. And they're often treated similarly. The problem is that if you look at all the studies, there in fact was a recent, again, presentation at San Antonio where there was a collaborative group of people throughout Europe who looked at all their data sets and basically tried to work out what happened to the men, because they're very rarely included in clinical studies. They're often excluded because the inclusion criteria will say female. You know, the information guiding that, again, is all extrapolation. But the only thing that we'd have to say is that, generally speaking, with hormonal blockade, we tend to use tamoxifen and not AI because of the fact that of the information we have, there's almost nothing about AIs and its role, and biologically it may work differently. So apart from the hormonal side of things, in terms of whether someone requires chemotherapy or Herceptin if it's hormonal, we judge that on the biology of the malignancy. But it's a challenging one because it's not very common. And as I said, they often present later because they don't think that they could get breast cancer.
Sorry, so just following on from that question, the entity of breast cancer in males is essentially the same in terms of molecular subtype?
Well, at the moment, that's the way that it's viewed. As I said, I mean, the problem with, like many of these things, unless you've got, because it's an uncommon malignancy anyway, if you had to recruit to and get enough numbers statistically and analyse it, you'd have to do, something extremely large, like you'd have to do an international sort of study. And so at the moment, we don't really have that information. The most information we've recently had is that presentation where they basically had a look at what happened to these people anecdotally, and what they found was that they were less aggressively treated, they sometimes didn't get hormonal therapies when they should have, and that sometimes their outcomes were worse because of the fact of the late presentations and the way they may have been managed. Yeah. So I know, for example, if someone presents with a male breast cancer, I will always refer them to the female cancer clinic just to get their opinion because it is associated with some of the BRCA mutations.
So what is your approach for inflammatory breast cancer? If negative ultrasound, negative mammogram?
Because it can be biopsy.
Yeah, biopsy. And then probably mastectomy?
What would usually happen is someone presented, so biopsy would be taken, they'd be seen by a surgeon, and then they would often be given pre-operative chemotherapy with Herceptin or not, depending on the biology of the disease.
So
and then they would try to shrink it down, and then they would proceed to a mastectomy and possibly axillary clearance, depending on whether they thought there were nodes involved, which they commonly are.
So biopsy with MRI or just biopsy?
Well, because you can often see it, so they just biopsy. It does, yeah. And sometimes, I mean, it's if you look on Google, they show the really extreme cases. Sometimes it can just be just a faint flush, and the breast itself can feel normal. But sometimes you've got the extreme cases where it's clearly very red, and there's penerange and all that sort of stuff. But it can be quite subtle. In terms of it doesn't have to look like that. I suppose the trap is that the imaging can look normal, and it's not uncommonly bilateral.
So can the biopsy be negative as well? And what do we do if the biopsy is negative and imaging?
Possible. I suppose the reality is that if you're worried about it, I mean the point is if it's just simple infection, it should get better with antibiotics. So if it's not getting better, something is happening. And I suppose the best thing to do is to think about it. And if you're worried about it, speak to a breast surgeon and say, can you just look at this patient for me? Phone a friend. It's just more about just thinking about it. Because again, I've got a very sort of view of the world, with what I see. Do you know what I mean? I think everyone's got cancer. So I'd probably be a terrible GP because everyone would have scopes and biopsies and that sort of stuff. So I don't see what you see, but what I do see is when they do present, you get people that have had 3 courses of antibiotics. Something's not working. Yeah, so that's what I'm saying. It's just, and again, I think that's what we do all the time. And again, I suppose it depends on how your practice works. Clearly, some people work in groups, some people work in smaller groups, but that's what you've got your peers for. And I think if you ask questions and say, look, I don't know about this feels wrong to me, no one's ever going to criticise you for that. Yeah, that's what I mean. If we have our multi-D meetings and we discuss things, and when you've got those cases where you're not sure, that's exactly what I do. I will ring up some of my colleagues from the specialty units in Melbourne and say, I don't like this, what are your opinions? And I'll even sometimes say, I actually want you to see this person. Because that's the other thing too, like when the person's sitting in front of you, then there's an additional responsibility to go through everything appropriately rather than just giving a corridor consult. So again, sometimes you just got to do that as well. You get someone to actually look at them. And again, I think no patient will ever, I would imagine, criticise you for caring enough that you want to get a second opinion about something. Yeah. Okay. So hopefully you got 3 things out of this. Okay. Thanks. very much.
Thank you.